Welcome. Today our team will present Adapting the Aaniish Naa Gegii, the Children's Health and Wellbeing Measure, or ACHWM, to include children aged 4 to 8 years. Background. Patient-reported outcome measures, or PROMs, are important for decision-making in healthcare. PROMs inform evidence-based practice and empower patients. One population who has been largely absent from the development of PROMs is Indigenous people in Canada. Indigenous children are particularly important to engage in PROMs because they are the fastest growing segment of the pediatric population, experience serious health challenges, and have limited access to healthcare. There are relatively few culturally relevant measures that elevate the voices of children and lead to solutions. In response to this, our team co-developed an initiative with First Nations, Inuit, and Métis children known as the Aaniish Naa Gegii, the Children's Health and Wellbeing Measure, and was originally intended for Indigenous children 8 to 18 years of age. The ACHWM contains 62 items that are aggregated into an overall summary score and 4 quadrant scores. It is based on an Anishinaabe medicine wheel conceptual model of spiritual, emotional, physical, and mental or intellectual health. Results are shared first with youth on a balance chart, leading to strengths-based conversations on wellness with the local health worker. The results from the children's survey responses are aggregated as a report to inform and evaluate local programs and services. The ACHWM can also support population health assessments and acts as a screening tool to connect children to local mental health supports. In light of these benefits, Indigenous leaders are eager to extend the age range of the ACHWM to include young children, down to 4 years of age. Objectives. This presentation describes how we identified an item set as the foundation for a younger children's version between 4 and 8 years of age, comments on the process of review and refinement of key items for the young child ACHWM, and discusses the procedure for assessing item relevance and consistency of interpretation by interviewing child caregiver dyads. This step is on hold until in-person research is safe. Methods and analyses. We designed a 3-step approach. The first step involved applying the rash measurement theory, or RMT, as a secondary data analysis to identify the best fitting items within the ACHWM. We also examined the location of items along the wellness continuum to ensure the items we selected spanned the full range of wellness while maximizing differentiation between children. The dataset included the ACHWM items and age and gender data for each respondent, as well as responses to the 62 items, each with a 5-point or frequency response set. These data were shared with us by 5 communities and represent a general community sample between August 20th, 2013 and August 8th, 2015. The rash polytomous model was used and all analyses were performed using RUM 2020. During the second step, the items were reviewed and refined for younger children by 3 experts. Further expert review is planned. 8 to 10 experts in children's health or a background in child development or children's mental health and working at the Children's Hospital of Eastern Ontario or the Mental Health Commission of Canada will be recruited. The team will create a red cap cross-sectional survey and administer it in the fall of 2022. The experts will be asked to assess each of the 25 items for age appropriateness, length relative to attention span, and identify any wellness items that should be added or removed. The survey will take approximately 60 to 90 minutes to complete. The third and novel step involves interviewing approximately 5 to 10 child caregiver dyads from one Indigenous community. Each will be of 30 to 60 minutes long, and they will be conducted in the winter of 2023. Children and caregivers will complete this task together and will be asked to think out loud and to describe what the questions mean to them. Specifically, a member of the research team will ask if each of these items are relevant, well understood, and if any concepts are missing from the item bank. Items will be amended based on child and caregiver feedback. Changes will be made when there are multiple dyads providing similar recommendations, and the process will proceed in an iterative way until a well-understood version is achieved. Note that children's feedback will be prioritized over expert recommendation. Results. Step 1. Item identification. Rash analysis sample characteristics. Data were available from 401 children across 5 sites with a mean age of 13.5 years. Almost half were girls. The most common global health ratings were typically good at 41% and very good at 25%. Most of the children completed the ACHWM at school. ACHWM score distributions. Observing Table 1, the mean of the ACHWM summary score was 74. Scores were scaled to a 0 to 100 range, where 100 indicates optimal wellness. The means for each of the scaled quadrant scores range from 61.9, like that in the mental quadrant, to 80, like that in the spiritual quadrant. Overall and revised rash analysis. Taking a look at Table 2, the RMT indicated moderate overall fit, with a raw chi-square of 809. All quadrants showed excellent overall fit. 32 out of 62 items showed evidence of disordered thresholds. To address this, we recoded all 62 items using collapsed response categories of 3 levels rather than 5. This improved the overall fit. The overall model identified 41 items representing wellness and 21 items representing illness. Step 2. Preliminary Young Child ACHWM. We created the foundation for the young children items by performing a unique and novel step, revising the original ACHWM to adapt it to young children. The process was informed by the rash analysis with a focus on wellness. There were 3 response levels ranging from never to always. 16 items were deleted due to misfit or overlap. The 3 experts revised another 16 items to fit the cognitive abilities of young children, leaving a total of 25 items. 6 spiritual, 7 emotional, 8 physical, and 4 mental. Additional guidance will be elicited in fall 2022. The following slides display select items from the preliminary Young Child ACHWM based on each quadrant. For example, one positive item pertaining to the spiritual quadrant is, I feel connected to Mother Earth. For the emotional quadrant, I like my community. Mental quadrant, I like learning. Physical quadrant, I eat healthy foods. In Step 3, we will finalize the Young Child ACHWM by listening to the voices of children and their caregivers in one First Nations community. This approach is also unique and novel, and might lead to a culturally appropriate way to encourage young children, parents, and healthcare workers to stimulate healthy conversations about wellness. Discussion. The only data available for comparison are the global health ratings from the First Nations Regional Health Survey. In Phase 2, from 2008-2010, 35% of First Nations youth in Ontario, aged 12 to 17 years, self-rated their general health as very good. In Phase 3, national self-reported general health of First Nations youth was very good or excellent. Almost 60% reported such. Our pooled percentage of 25% suggests greater need for support. We may be capturing children who don't participate in typical health surveys and might be even more vulnerable in comparison to children from the rest of the province and across Canada. Moreover, other groups of researchers have applied RMT methods to data from an Indigenous sample to refine a quality of life tool from the United States and to support numeracy testing of Indigenous and non-Indigenous children in Australia. Both studies had similar sample sizes and support the usefulness of RMT in Indigenous populations. Conclusions and next steps. In Step 1, we used rash analysis to identify wellness items for a younger children's version of the ACHWM. The resulting 25 items are conceptually and psychometrically sound in older children and cover the 4 medicine wheel quadrants. The ACHWM creates a roadmap for the types of culturally responsive services that can address the health and wellness of Indigenous youth. In Step 2, we have begun to integrate expert feedback with more coming. In Step 3, we will finalize the Young Child ACHWM based on feedback from child caregiver dyads. We aim to retain the full scope of the measure. Future research will involve testing the validity of the Young Child ACHWM versus a mainstream quality of life measure known as the PEDS QOL, and facilitating it in diverse Indigenous communities across Canada. Thank you for listening. Miigwech. If you'd like to get in touch, please feel free to contact us on one of our platforms. Goodbye.